So just like to introduce the first speaker. We're going to do questions at the end. We'll keep the questions at the end. So just introducing Ahmed Ali, who I'm sure is known to everyone here, the head of upper GI surgery at Austin Health, the president of this Congress. What you might not know is that when Ahmed was the president of ANZMOSS, his focus was public bariatrics. It was a key element to his presidency, and he developed the public bariatric surgical framework, which is basically a manual on how to set up a public bariatric unit. So we have that all there if ever you wanted to introduce it to your institution. But Ahmed's going to talk today about the overview of public bariatrics in Australia at the moment. Thanks, Ahmed.
Thank you, Jacob, and good morning, everyone. Thanks for attending, and I hope you're all enjoying the conference, and for those of you who are visiting from outside of Melbourne, enjoying the city. Thanks for your kind words, Jacob. I think you might have overstated it, but yes, the framework is I guess, the first step towards trying to achieve something along those lines. I do want to acknowledge, I'm going to focus on Australia mostly, but that's not to neglect our New Zealand colleagues, because they face very similar issues with regards to public access to bariatric surgery. So I just want to make that acknowledgement and then move on into the Australian data. And most of the data in here comes from a variety of sources. There isn't really one place where you can get all of it. It really can be quite difficult. So I've tried to piece it together from a number of sources. So briefly, this is not news to anyone. This is sort of recent data across Australia. In adults aged over 18, 66% overweight or living with obesity, 32% are living with defined obesity by the old criteria, notwithstanding the plenary session today, and 13% living with severe obesity. And perhaps more alarmingly is that as obesity increases, it's the more severe spectrum of obesity that is on the increased most rapidly. And that, of course, will then have a more significant impact on health of individuals and correspondingly our society. As you know, obesity is a contributing factor or in causality or in at least by exacerbation for almost every body system there is. And so I guess I put it to policymakers, I put it to us to challenge ourselves, is that if we're really serious about providing healthcare to our society, to our community, then we can't really do that unless we address obesity. And obesity is probably the condition that is most poorly addressed nationwide in our health system. Surgery, yes, the GLP-1s are on their way and they're getting better, but currently surgery is still the most effective therapy we have in terms of weight loss and restoration of health. And there are numerous studies that show economic cost benefit in surgery, particularly when it comes to looking at things at an individual level. So we have our most effective most effective treatment for this condition, which we've already established does demand attention. And so if we take all of those, the Australian population, and we look at those who might be, and I acknowledge this is old criteria, but they might be eligible for surgery, the BMI over 35, and then you'll refine that down to those that have the appropriate comorbidities that would include them as candidates. We're actually only reaching under 2% of those people by surgery in Australia overall. In other words, we're using the most effective therapy in less than 2% of patients in the condition that probably affects our health most greatly. Makes me feel a little bit like this guy. And so if we take that as 1.5% of patients that are actually accessing surgery, if you're at the back of the room, you'll have to watch really carefully. This is how many we treat in public. I won't labour these, the data here. I've just put pretty pictures for you to look at, but 8% of all surgery was performed in public hospitals in the 2014 year, and only 4% of that was actually publicly funded. So a lot of them were actually private patients anyway. So if you really want to be sort of mean about it, you'd say, well, we're reaching 0.18% of the eligible population in the public system, at least in 2014 and 15. And this is probably a little bit cheeky. I've said there's 700 public institutions in Australia. That's true. Not all of them would be capable of delivering bariatric surgery, but nonetheless, there are only 15 back in 2014-15 that were actually delivering any form of public bariatric surgery, in public. And sorry, I didn't put the reference for this one, I forgot. But This was a small study put out by COSI PH at the time that looked at what those services looked like, both medical and surgical, and there was a wide discrepancy in how those services were resourced. There was no standardisation. Some had good resources, some had very difficult resources. Really, even though the number of services are very poor, also the resources available to them are very poor. So where are we now, 2024? Well, I'm afraid we're no better off, really. This is data from the registry. Yes, it doesn't actually capture all of the data around Australia. It's about 80%, which is not bad, but it's still reflective of what's going on. We're still at around that 5% mark of public bariatric surgery, or bariatric surgery being publicly funded, and we still have wide state-to-state discrepancy on what's available. The number of sites have increased a little in the BSR. There's 22, but unfortunately only 7 perform any with any real volume, and they're predominantly in Victoria. So again, we have that statewide discrepancy. And so we really do have an equity of access issue here. And if we pride ourselves in our health system of providing equal and adequate care for all Australians, we ain't doing it. There are reasons beyond equity to consider the importance of bariatric surgery. It's not just about equity, although I think that is incredibly significant and was what was, I guess, motivating many people at ANZMOSS to look at this. The other thing is we all know about the obesity stigmatisation, and the reality is if the treatment for obesity was normalised by being in all of our teaching public institutions and just part of routine medical care, it starts to reduce the stigma, it starts to address obesity as something that requires treatment, it normalises that and changes the language subconsciously. It's also important, of course, for surgical training, because that's where most of our surgical training occurs. So how are we going to train adequately registrars and fellows, etc., in bariatric surgery if we're not exposing to the place where they can actually use their hands under supervision? It creates a whole training dilemma. But beyond that, from I guess a philosophical point of view, we're also not delivering appropriate treatment for a whole host of conditions. Weight isn't the trigger for surgery really anymore. We're trying to treat all of these diseases as well. And there are numerous guidelines, and this has been done a lot, particularly with diabetes, where surgery has been incorporated into the algorithm of the treatment of that disease by non-surgeons. So this is one of the diabetes ones, and it says, you know, when you're in this sort of situation, you should be considering strongly or doing bariatric surgery. And so if that's the algorithm of the treatment of our disease, and we don't have that available to us in the public hospital, then we're not meeting standard of care in a whole lot of diseases, certainly diabetes, but increasingly osteoarthritis, liver disease, sleep apnea, cardiovascular disease, and I'm sure we can continue to accumulate knowledge and evidence of this. So we're delivering substandard care for a whole lot of diseases in our public hospitals because we don't have access to one of the tools that is required to treat it effectively. There are other consequences of not having available public bariatric surgery, and that is what I call the insurance temporary dilemma. We all know the ones, everyone practicing in private, that patients take out insurance deliberately to have bariatric surgery and then they drop it once they've had their surgery. The insurers cannot make money in that model. They always lose money on that model, which is why they then drive that into the highest brackets of insurance. They have to provide it, that's part of the Insurance Act, but they want to try to make it as expensive as possible because they keep losing out and they want to make it. In other words, they're trying to create a deterrence, which only limits access to this treatment further. People are accessing their superannuation or they're self-paying, and that's creating financial risk for those individuals. And the other thing it does is it creates a whole lot of legacy patients that if they have problems like complications or they need revision, they end up in the few public services that are available. And when we studied our cohort at the Austin, we found that, in fact, of all the revisions we were doing, 77% were legacy patients. They weren't even the patients that had had primary surgery. And of course, that's then taking space and opportunity for other patients to be treated. So what's the problem then? Why can't we advance this? Well, in 10 years, we've made really no shift. What's the problem? And we've made attempts, we've advocated, we've done all sorts of things. Is this a problem of not being able to demonstrate efficacy in the public system? Well, the answer is no. There's actually a fair accumulation of local Australian data from the public system demonstrating that bariatric surgery delivered in the public system is as effective as in other scenarios. I won't go through them all, but that's the bottom line, that's the message. And indeed, there's good data to show that the demographics are different. So they're older, they're heavier, they have more disease, and yet we're getting similar outcomes in the public system. So efficacy is not the question. We can deliver it. Yeah. Is this simply a problem of recognising that obesity needs treatment? Well, no. I'm only using MSAC here, but there are many other bodies and reports that have been over decades, actually, to the government, highlighting the problem of obesity and so on. And this is when MSAC reviewed the bariatric item numbers and they looked into it, and they were surprised by the disparity in public and private supply of surgery. They recognised that disparity in their report back to Parliament, in the discrepancy between the public and private systems, and they recommended the implementation of an access pathway and a defined treatment pathway for patients. And I actually recommended it quite strongly at the time. And it's partly what led to us trying to develop these sort of broad guidelines on perhaps a model of how to deliver public bariatric surgery nationwide. We tried to do it by a consensus so that, again, one of the problems with government is if you have too many voices, they just pick who they want to listen to. So you kind of need one voice if you can manage it, which is always hard, especially in a room full of surgeons. So, but we tried. This is where we got to, and we had a document we were about to launch, and then COVID came, and that sort of made things much more difficult. So it still exists. So what are the true barriers then? If it isn't about efficacy, it's not really about recognition. The government knows. What are the barriers? And I guess we can guess at them, but obesity stigma is still a very big one that operates at local level, state level, federal level, every level. And until we can get around that and stop the perception of it being a lifestyle disease, I think we're always going to struggle. And of course, there's very little empathy for patients living with obesity. It's not a vote winner. It doesn't you complain, it doesn't really matter. So that's difficult. There's political fear about the cost. I mean, economists are very good at looking at cost. And then the question of the floodgates, because it's a highly prevalent disease. And so the question becomes, well, is there value in bariatric surgery? Should we be spending the public dollar on that? Yeah, okay, you show that these people all get better and that's nice, but is that really, where's the value? How do we know that we're doing it in the right people? And so I want to spend a minute or two looking at this sort of cost value. I must admit I was doing this for the minister, so if you want me to stop now I can, but there's been lots of studies that look at the cost of obesity, and I'm no economist, so don't ask me to explain this, but there's direct cost, indirect costs, and loss to well-being, etc. The wider you look, the more money you can throw at this. But the thing is, it's expensive, right? It's prevalent, it costs a lot of money. How much does bariatric surgery cost? Well, that's always a little bit hard to answer as well. It's a bit woolly. Here's some data I found in the New South Wales Cost of Care study in 2017, just looking at direct cost of the operation, okay? This is not total cost of delivering the care, it's nothing like that, but this is just, on average, the cost across the hospitals, this is what they estimated, and bariatric surgery compared very favourably. It wasn't a particularly expensive operation to do. Now, we can talk about service costs and so on. And again, like I said, there's a lot of cost-benefit analysis, all that sort of thing. This is a simple surgeon's sort of way of looking at things that, it's just a hint. But if we know from good long-term data that we reduce risk, we know that we can reduce intervention in other areas. The numbers on the right there are all from the Swedish obese subjects study in terms of how much that risk is reduced by long-term weight loss achieved through surgery. And so you just look at it and say, well, if the operation cost me 11,000 and all these other things cost me this much and I'm going to reduce that relative risk, then sure, I'm making some cost savings. And there's been some interesting work in transplant and osteoarthritis demonstrating that patients can come off waiting lists for some of those conditions if they can lose appropriate weight with bariatric surgery. So there's going to be some sort of trade-off in that sense. But here's the problem. It's a big problem. There's a lot of people. And again, just trying to use the standard sort of criteria, potentially eligible for surgery, about 1.8 million people. And that's what the policymakers see. And if we're realistic about it, you can't treat all those patients. It'd take us over 100 years, and that's without adding new patients or revision patients or anything else, and it's going to cost a fair bit of money as well. And that's just direct cost. That's just the cost of the operation. That's not counting everything else. So, and so clearly, bariatric surgery is not a population-level intervention. We help individuals, we know that, but at this stage we still only help relatively few. And so when you're talking to an economist or a big picture person, they look at it and say, well, look, you treat 2% of the population, you're not really making a meaningful impact on that 52 million of costs that we were talking about earlier. That cost argument's not going to work. You're not really making a meaningful impact on a global scale in terms of health. So do we really need it? You know, aren't you happy just treating a few people like that? That's okay. Question is, could we do better? Can we find better value? Could we get a better target? This is a paper from 2022 that had an interesting way of approaching it. So, well, what if we had a penetrance of 20%? What if we operate on 20% of these people? And we used a selection criteria based on the public framework that we talked about. I didn't go into the details of that, but that's what they kind of used. And so just briefly, they sort of looked at it and they modelled all sorts of different things. But in this part that I pulled out, they said a 5-year program at 20% is about 68,000 cases a year. Most of that will have to be absorbed in the public because the private is kind of saturated anyway. And that's where the expansion would be, but it isn't quite as expensive. Again, direct cost, not global cost, just direct cost. But you could probably do it at a pretty reasonable level. And so it comes down to, well, do you want to swallow the red pill or the blue pill? Who do you really believe? 68,000 operations a year is still a lot, but it isn't out of reach. It's possible. That's sort of a combined total of our gallbladders and hernias currently. So, it's potentially doable without opening the floodgates, as long as sufficient number of hospitals were able to provide a service. Of course, the government only feel direct cost. They can look at those big numbers, the 52 billion from all of those PwC, who are on the nose a bit now, aren't they? But anyway, they can look at all of that, but no politician's ever going to feel that. It's not actually going to directly affect. It's hard for that to influence policy because it's just too big a picture. It's the short term, it's the upfront cost. And again, like I said, it doesn't inspire empathy. It's an invisible sort of disease. I just threw this in, I was just playing around and said, what if we just treated diabetics with surgery? Well, actually the numbers start to become really quite realistic, but I started all of this talking about equity and equity of access and for, treatment of patients that would benefit. And yes, diabetics benefit, but so do lots of other people. So I'm not necessarily advocating this. I'm just saying that if we shift our focus, change our target, maybe we can do something really useful. And of course, we're now in the GLP-1 era, and that's changed things, and it's going to change our treatment paradigms. It is going to change who we operate on. And now I think we're even more confused about who we should operate on, and that's probably going to be the next target that we need. So, are we going to make it based on how much weight loss people need, or are we going to make it based on how sick they are? Or I don't have the answers to those questions, but I think they're actually important questions, because I think that's what's clear, that we need to sort out what the indications for surgery are for the most value, both clinically and economically, when we're trying to make this public bariatric argument. This is an evolving space, and I think it's going to change, and we need to be agile to follow that. Or pivot, that's our word, isn't it? Can we actually achieve precision treatment where we know what treatment will work for what patient? I think that's the holy grail. If we could do that, then I think we make a much easier argument to, but that's a long way off. And it certainly demands more strategic research. I'm not going to talk too much about this because I think Paul Burton might talk about how to feel good in this, rather depressing area. But thank you for your attention.
Thank you, Ahmed, for starting the discussion.
Pleasure now to invite George Hopkins up to speak. George is filling in for Anna at last minute, so thank you.
Disappointment.
Yeah. George is, of course, a very, very busy private surgeon, but also remains committed to the public service through his work at the Royal Brisbane Hospital, which is a terrific high-volume public bariatric service. So thanks, George.
Thank you, Jacob. Paul, at the end, you need to answer a question for me that the Dan Andrews fall, Wendy Brown was telling me all about it the other night, and she said when Dan Andrews fell down the stairs, and I don't know what that means. So he was either pushed or he threw himself down the stairs. Someone needs to clarify that for me at the end. So look, I was very happy to step in when Mark asked me to. I'm actually really optimistic about what I can control and what I do. I know Ahmed's version of it on big picture, and this is what we talked about at the J&J dinner last night. The big picture is really hard for clinicians I try to keep a focus on I can really only help the patient sitting in front of me and do my best to improve that. Now, our public hospital access is actually growing. And the really big dilemmas that we've got, I mean, you couldn't describe a more complicated system than the one we've got in Queensland Health, but they have actually done the right thing. As in, we've been offering a general surgical bariatric service for 20 years, and then a group of endocrinologists got together to demand, and I really do want to make this point, that when surgeons advocate for surgery, we get told, well, you would say that, wouldn't you? But when the endocrinologists or the physicians start pushing for the surgery, they literally will be listened to. And they don't sort of seem to have a bias in it. So in 2017, and it's a really sort of a pivotal part of our service, Tricia O'Moore-Sullivan, an old friend of mine, an endocrinologist, and she put a group together to say, we demand that our type 2 diabetic patients get access to this service because this is the standard of care. She stood in a room of maybe 300 people and said, if you don't believe that this is the right treatment, I would urge you to leave the room because you don't understand the literature. We need to get on and do this. So, and I will always push the fact that I think on balance that we can only do what we can do, and I'm very optimistic about what's in front of me. The big picture numbers, Ahmed, it's mind-blowing, and almost certainly that's why the health minister, or whoever that was, she probably looked at some of those numbers, and they are questions she probably can't answer. So look, we have a general surgical service, and that's a really important component because there is another public hospital that does it, but we've been doing it for 20 years, and we are the reservoir for all the revisions. And the biggest problem in public bariatrics, to be brutal with you, is the problems. So we have a particular service which is diabetic-led, and this is the one that started in 2017. And we had sort of fairly strict criteria, and even more strict was how you got access to that hub of referral. In other words, you had to be a staff specialist in Queensland Health. When this started, it couldn't come from general practice. And you had to have a certain, what I would say, degree of diabetes. And I had some serious reservations about the diabetic requirements, mainly because, even requiring a HbA1c to be at a certain level, and you needed 3 medications. And some of this stuff was, to me, implying, so we're going to do the less compliant patients. Because if someone was really compliant and tried to do their best with oral intake, they'd actually have a better profile, and therefore they wouldn't qualify. So we had this sort of unusual game of me versus the endocrinologist, because they were serving up the sickest, saddest, most non-compliant patients. And I'm like, well, if someone's been on their insulin for 10 years, I can't fix that. I want the pre-diabetic or the newly diagnosed diabetic. So we had this sort of push and pull of where do we direct our services. On balance, I was rejecting more patients than I was doing, because of course there's a full MDT that goes with it, including endocrinology and the whole allied health. But of course the surgeons get to yay or nay, and I just that is not a priority. Yes, that's just my decision in my head in that MDT. Is there a better patient in the next one? Because we only get to do a certain number. We've got protected lists. They are only for bariatric cases. But the reverse to that is you only get to do those cases. So again, to make you understand that if a revision comes in that needs to be done, we don't add that to the list. We have to take an elective primary case off a list. So this is also the game that we play with the swarming numbers of sleeve refluxes, weight regainers, and they are sort of pushing all our buttons all the time. And in fact, if you attend one of my public hospital outpatient clinics, you'd be appalled by bariatrics, because we are only the reservoir of the failed and miserable. No one who's done really, really well comes back to see me to say I've done really, really well. Particularly, and they shouldn't, not from Cairns, not from Bundaberg. So you just go from problem to problem to problem, trying to stratify. Did I just lose that? That's just fallen off my... All right, I can't see now. It's come off. Can I see there? I can't read that. So exclusion... I can't read. Exclusion criteria. Well, smoking, this is an interesting one that came up in Christchurch last year, that some people regard exclusion of smoking to be, well, a version of racism. And particularly in the Maori population, and the Auckland guys did take smoking as an exclusion criteria out, because 2/3 of the Maori population smoke. And it was considered, and again, we do know it's best medicine, and I maybe argued to Grant Beeban a bit aggressively that so he was just able to do more dangerous surgery on the Maoris than he would tolerate from the Anglo-Saxon population. It's difficult, but at the moment smoking is an exclusion criteria. Some of them are fairly obvious. I want to just go back a slide, sorry. Can I go back a slide? No, really? Okay. Yes, the other, the top four, so the diabetes is the easy one. So what actually happened subsequent to the type 2 diabetic program was other specialists were coming to me saying, I want access to that service as well. And I said, well, actually, that's not my problem. I'm now making that your problem. You apply to the hospital for your endometrial hyperplasia, the gynecologist, for your idiopathic intracranial hypertensions, and for your transplant potential recipients. So what I actually got them to do was they did all the work for me. I just said, when you've convinced them, I'll do the cases. And it actually worked quite well. So they are now our criteria. And look, we can talk all day. We've also got an advocacy group for the Indigenous population, and in fact, there's a Queensland Health directive that they go straight to Cat 1, so they're done within 30 to 60 days as Indigenous. Now I'll go to this next one. So we do have some exclusion criteria. Again, all this is a little bit, in my head, loose. I mean, unstable mental health condition seems reasonable, but every one of our patients pretty much in the public hospital has some form of stable mental health condition. Trying to take on the challenge of reduced IQ. For example, I saw a young boy last week who, he had an NDIS worker because his IQ must have been 50, 60. Now, I didn't say no. I just said, I'm going to actually see him a little bit more often than I would normally see a patient, because he couldn't really answer any of my questions, and his NDIS worker kept answering. And then I said, it's not really me explaining it to you, it's explaining it to him. But then he said, you don't understand, doctor, I'm a bariatric patient too. And I said, I'm not sure that's relevant, so just pipe down. He was an advocate for his patient, but I don't know what to do with the low IQ. But that said, I'm entirely sure most patients, in actual fact, one patient was excluded when the psychologist said, I don't think that they have the health literacy. And I said, I need more information. They don't really understand what's going on. And this wasn't an IQ, this was a health literacy. And I had to say to the psychologist politely, I don't think you really understand what I do up there. I mean, seriously, she's never been in an operating theatre. And to make the call that they had a poor health literacy, it's hard to get patients to really understand what we're trying to do for them. Now, we have been working towards our clinical and operational reference group, that's called the CORG, about trying to get assessments and prioritisation. Again, what became very, very strange in our newer diabetic service was it was so hard to access, we didn't have enough patients. So our prioritisation tool sort of took a back seat, because we had unfilled lists in a public hospital doing bariatrics. And it was a very sort of funny period of time. And look, yes, the COVID made it even funnier, but to this day we are still not getting through the referrals. But again, we've made it so difficult to get access to the hub of referrals. So we are about to introduce general practice as a referral source. Next one. Now look, some of the other issues which I just want to touch on is, Ahmed's made the point, and Paul, it's about training. And the dilemma in all public bariatrics is that we've got a dilemma of, if the fellows are doing the cases, if I'm doing a caseload, I can do 6 or 7 in a day, probably more. But if the fellows are doing it, it's suddenly taking longer and longer. And even in the anaesthetic bays, it's taking longer and longer because the anaesthetic registrars are doing the cases. And people get stunned by how little work we can get done in a day. But again, I'm trying to keep my hands off because we've got a very unique environment there. I only do bariatrics in the public. I don't do hernias, gallbladders. This is all I do, but we are still constantly playing this game of trying to get the cases done whilst training the fellows. And the fellows need to be the primary operators, and they actually need me mostly sitting outside, not inside. But that has to be weighed against trying to get through the cases. And as I say, the other really big dilemma is the complicated cases coming from the private sector. The huge volume of self-funded patients who cannot have their problems and issues managed means that we have an overwhelming volume of revisions that need to be prioritised, and that's like a whole nother session about how we prioritise managing, when does sleeve reflux get to the point that it needs more surgery. So look, I will leave it at that because I was just a step-in team, but in actual fact, I've got everything I've asked for, Ahmed. I said to someone yesterday when we were discussing this, my whole wish list from a decade ago actually came true. I've got every single person on that list. And they're enthusiastic and they're all at the back, and I thank them for that. We have a really positive attitude to it, but I was asked to address the dilemmas, and they are our dilemmas, but I'm actually on the more optimistic front. But again, not big picture. My small picture I'm pretty optimistic about. I'll leave it at that.
Thank you, George. Obviously living the dream in Brisbane. We're going to go rural now, and it's my pleasure to invite Nick Williams, our president of ANZMOSS, come tomorrow. So, welcome.
Thanks very much, Lillian. Thanks for having me, guys. So this is really a little bit of an addendum talk really to what Ahmed's already covered, because a lot of the themes are, of course, very similar. And we all know that what we have been doing over the last 20 years, this is in New South Wales, has been completely ineffective. There are no blips in those graphs whatsoever in terms of the rates of overweight and obesity, which just slowly but steadily increase and increase over time. Looking specifically at some of the New South Wales data, we can see that there is an enormous difference in obesity rates between regional remote and metro. So up the top there we've got Far West, which is a very large health district which covers most of all of Western New South Wales, and that in fact is also the largest primary health network in all of Australia. And New South Wales also has the skinniest local health district in all of Australia, which is the North Shore of Sydney. And so you can see what an enormous difference there is. Murrumbidgee right in the middle is where I work. Furthermore, we know that Indigenous patients, there's a lot more of them in regional and remote than there are in metropolitan centres. And of course, over the last 10 years, the percentage of Aboriginal people who are living with overweight and obesity has steadily increased from about 57% in 2014 up to now 72% last year. And despite all of our best efforts, Aboriginals still have a drastically reduced life expectancy. Males living 9 years less and females 7.5 years less, and that's for people born today is the prediction. Looking at our local health district, we have approximately 6% of our population are Indigenous, and yet the patients who have accessed our public program, 10% of them are Indigenous, so almost doubly overrepresented in the patients accessing surgery. And they're the ones who are accessing it. There's going to be a whole lot of other Indigenous First Nations people out there who, for a range of reasons, distance, time, costs, cultural problems, are unable or unwilling to access public bariatric services. So as Ahmed touched on, we're really not doing enough. We're not doing enough in rural, but we're not doing enough full stop across the board. This is the registry report, which only just came out in the last couple of weeks, and it showed that last year the registry only recorded 16,000 new primary bariatric cases across Australia, and that's actually the lowest number since 2017. And of those, 95% are still done. in the private sector. And so, Ahmed, I think you said that in order to operate on these patients, it'd take 200 years. I took another way to look at it, and that's if we recruited every surgeon in Australia, and I think there are about 6,500 registered surgeons in Australia, including, orthopods, everybody. And we said to all of them, right, you're all going to do a list of bariatric surgery every week, all of you. It'd still take 2 years to treat all of the patients in Australia who would benefit from bariatric surgery. And that's, of course, assuming that we could teach orthopaedic surgeons to do sleeves. Yeah. This is a map of North America. I think this is predominantly an Australian audience here today, but this just shows the population density of North America. And now we'll compare that to Australia. So each little yellow dot represents a place in Australia with a population of 1 person or more. And this is from a 2021 census. And so you can see that the vast majority of Australia is actually just empty. We all live around the coast, and most of us on the east and the southeast. When we look where we sit in the globe in terms of population density, we are right down the bottom. We're in the bottom 5 countries in terms of population density, which I think is obviously a good thing. We have a density of 3 people per square kilometre. So we're down there with sort of Greenland and the Sahara Desert. In fact, we're outnumbered by kangaroos in this country by, I think, a factor of about 2 to 1. There are about 45 million kangaroos in Australia. So, how are we going to treat these regional patients, the patients who are regional and remote and are suffering from obesity? A couple of interesting studies, and these are old ones now, but come out of the US about patients' willingness to travel for care. There's one from 2005. Some of you have probably heard of this, about mastectomies. And they studied mastectomy rates in women with breast cancer. And they found that depending on how far away you lived from the nearest centre that offered radiotherapy, people were more likely to opt for a mastectomy rather than to travel to have breast-conserving surgery and radiotherapy. And, that's actually quite shocking that people would literally have their boob cut off rather than travel for treatment. A similar study from 1999, again in America, looking at Whipple's resections, and this was sort of a thought experiment. They interviewed a bunch of people, and they said, okay, you've got pancreatic cancer, you need a Whipple's. Let's say the mortality is 3% in a high volume centre. If you could have treatment in your local centre and the mortality there was also 3%, what would you choose? Well, unsurprisingly, 100% of the patients said, well, I'd have surgery in my local centre, please. But then where it gets interesting is when you double the risk and you say, okay, the risk at your local centre is now 6% mortality. Half the patients would still opt to accept that increased risk and have their surgery done locally. And it goes on, and even if you go to 6 times increased risk and say the mortality is now 18%, 1 in 5 patients would still elect to have care in their close to home. So whilst I understand in our geographically sparse country, states like Queensland, everybody has to travel to George for surgery, for public surgery. That's not ideal. It's not ideal. Another one from America, again looking at regional, remote and socioeconomically disadvantaged people. This was a study of 750,000 patients in America, just reviewing hospital records. And essentially, they just showed that regional people were not getting surgery. And in fact, if you were non-white, if you were male, if you were poor, if you were old, if you were sick, and if you weren't privately insured, then you have 0 chance, essentially, of getting access to bariatric surgery. So, what are we doing about it? Well, this is my hospital. So this is in Wagga Wagga. We are in regional New South Wales. So for those of you who think that I operate in a cowshed, actually it looks nicer than your hospital, Jacob. So should we have a centre of excellence in bariatric in every regional hospital in Australia, well, why not? The reality, of course, is that we don't, and in fact, we're the only one. We're the only sort of hospital that has a mature public bariatric program in regional New South Wales and I think in regional Australia. So maybe we should just do it by telehealth then. Maybe we should force people to go to tertiary centres and get their surgery done there. This is a little paper, Paul O'Brien, it's a few years old now, but no surprises, they showed that greater pre-surgical wait, but also travel distance for follow-up were the most common factors associated with attrition rates in follow-up. And then out of COVID, some more work was done to see if we could really take this idea of telehealth forward. And whilst 3/4 of the surgeons who were interviewed did feel that it could be appropriate to do telehealth, only around a third of them thought that actually delivered equivalent quality care to seeing patients face to face. So then the next question, I suppose, is, well, is the post-op care important at all? Maybe we should just do the surgeries and then just let people sink or swim. Little study here again from Australia, and then no surprises, they showed that the excess weight loss at 1 year after gastric bypass was linked with compliance with follow-up. And of course, there have been more studies since which have also proven that same point. So is it safe to do it in regional centres? Is it effective? We're not talking about doing Whipples, about doing complex upper GI surgery. In all of these centres, we have surgeons who are already doing large volumes of bariatric surgery in the private. And we're just talking about setting up equivalent services in the public hospitals. Ahmed's bariatric surgery framework from 2020, which I don't think really got the fanfare that it deserved, because unfortunately it came out sort of right during COVID. But he makes a very good point in there that in order to set up these services, you need to have local solutions for local problems. And there is no such thing as one perfect, ideal way to set up a program. You have to tailor what you offer to your community and also to the resources that you have. So, for example, in our unit, our medical lead is not an endocrinologist, it's actually an anaesthetist. He'd like to consider himself a perioperative physician, but nevertheless, that actually works really well for us. It helps us to prioritise patients, to get them optimised for surgery in as short a time as possible, and to get people on and off the operating table as safely and efficiently as possible. And if we can do it, there's no reason why it can't be done in other centres like ours. So then, in conclusion, the topic of this was, well, what is the dilemma? So I was thinking about, what is the dilemma? Like Ahmed, why aren't we doing a better job? And I think there are a few points worthy of discussion, and these have already come up in the other talks, so I won't labour them. But one interesting thing, particularly in New South Wales, is that there are different types of obesity clinics. There are those that are sort of surgery-focused, surgery-led, like ours, and we are funded to do 50 cases a year, and we do 50 cases a year. There are other services which are led by endocrinologists, by physicians, and I'm not dissing them in any way, shape or form, and a lot of their patients are not suitable for surgery and they have, medical treatments. But a risk in those types of setups is that surgery can be seen almost as an adjunct, as an option once all the medical care has failed. And that ultimately means that then less patients are getting surgery, not even meeting quotas. Making a business case, as Ahmed talked about, is difficult. I rang my CEO, who I really like because she did help us set up this program back in 2018. And I said, what advice should I give to surgeons in other local health districts who want to set up a public program? And she said, forget it. Like in the current environment, it's just not going to happen. We don't have the resources for new services. We're still playing catch up after COVID. And when I pushed her on it, she said, well, really, the numbers have to stack up. It's all about money. And it's no point sort of saying, once we get our program set up, it will eventually save you money in the long run. They're not interested in that whatsoever. You've got to be able to demonstrate that what you're going to set up is going to be a financial benefit to the hospital from the day that you open the doors. Preventative treatment is also sexy, so I think selling what we are doing not necessarily as a treatment for obesity, but as a prevention for other health conditions, framing it like that is also important. As Ahmed mentioned, it's not politically sexy really to talk about obesity. We are still dealing with a lot of weight stigma, not just with obesity itself, but also stigma with the operations themselves as legitimate treatments. And that's all I have. Thank you very much.
Thanks, Nick. I think you also need to take a lot of credit. Setting up a public bariatric surgical service in a rural area from de novo is an impressive effort, just to prove that it can be done if you're committed. So thank you, Nick. I'd like to now invite Associate Professor Samantha Hocking, who's an endocrinologist and a clinical academic at the University of Sydney, who also runs the Metabolism and Obesity Service at the Royal Prince Alfred Hospital, and is also the current president of ANZMOSS. NACOS, sorry. Who's
okay.
now going to talk on the physician's perspective on public bariatric surgery. Thanks, Sam.
Thanks so much, Jacob. So thanks very much for the opportunity to speak. And I did try and speak to some other colleagues to present physicians with the apostrophe after the S rather than just a single physician's perspective. But some of these opinions are mine, but some of them reflect sort of the positions of my colleagues as well. These are my conflicts of interest, and probably my other conflict of interest is that I do work in a medically run obesity service that also offers public bariatric surgery. That is sharing 100 bariatric cases per year across 4 different hospitals and 1 Aboriginal medical service, so we don't get a lot of opportunity to refer. So in terms of the physician's perspective, what I thought I would talk about, and it's been covered so I won't linger on it too long, is the access to public bariatric surgery, then the efficacy of public versus private bariatric surgery, because the patient population is different. There's perceived safety of bariatric surgery by physicians, then the dilemma of medical therapy versus bariatric surgery, attitudes to bariatric surgery, and then do public clinics create barriers to accessing bariatric surgery? And I probably should put the caveat of, do medically led public clinics create barriers to accessing public surgery? So first, you've already seen this data. There's very, very limited access to public bariatric surgery in Australia. This is from the Bariatric Surgery Registry. And we do have a sort of disproportionate amount of revision surgery in the public system compared to the primary operations. I'm sure you've already seen this data already. This is another really interesting modelling study which looks at new onset obesity in Australia and whether there is access to that in either the private sector or the public sector. So this is modelling, it's always got problems, but this is basically not looking at people with existing obesity, this is just new onset obesity, and if you have new onset obesity and you're lucky enough to have private health insurance, actually the demand for the surgery doesn't outweigh the supply in the private sector, but if you don't have any private health insurance and you're purely relying on the public system, you can see that it's the exact opposite, that the supply is well below the demand. So it is much harder if you are a public patient to access this highly effective therapy for treating obesity. In terms of is public bariatric surgery as effective as private bariatric surgery, and the reason why I think public hospital clinics think about this issue is because our patients are older, they have higher body weights, they're usually sicker, and if they have type 2 diabetes, they're usually on more therapy for their diabetes and they're much more likely to be on insulin. So this is, again, data that was taken from the Bariatric Surgery Registry in Australia. And what it showed is that the operations, whether they're government funded or privately funded, are as effective in the longer term. So at 4 and 5 years, they are as effective. But in the first couple of years, there is a discrepancy in how effective they are. In terms of resolution of diabetes, which is one of the things that's captured in the Bariatric Surgery Registry, they're just as equally effective, even though the patients with diabetes are arguably sicker in the public system versus the private system. So there's no real concern that we shouldn't be doing public operations because we don't get the outcomes that you see in the private system. The next question is, well, is it as safe to do an operation in the public system compared to the private system? And again, looking at this data, if we look at the graphic there, figure D, that looks at the incidence of defined adverse events. And even though there are some numerical differences there was no statistically significant differences. But then if you looked at a whole lot of individual listed complications from bariatric surgery, there were more wound complications, more leaks, more reflux and dysphagia in the public compared to the private system, and there was a higher mean length of stay in the public system compared to the private system. But overall, what that particular paper showed was that it's very effective to perform public bariatric surgery compared to private, that yes, the public patients are demographically higher risk than compared to the private patients, but apart from some small differences, say in, for example, length of stay, those defined adverse events weren't any different. So really we shouldn't be concerned about doing publicly funded bariatric surgery or worried that the outcomes are not the same as the privately done bariatric surgeries. But what about then the perception of the physicians in the public clinics? And I think this is where there is maybe a bit of a problem, because we do tend to inherit the disasters from the private system. They all end up in our clinics. And so we see more people with severe reflux after a sleeve who then may need a revision surgery. We see the people who haven't done very well and are struggling with weight regain. We can sometimes have patients with really profound nutritional deficiencies. Why that happens, I don't know, but they tend to end up in our clinics. Post-bariatric hypoglycemia is becoming an increasing problem, and it's beginning to block our medical clinics. Post-bariatric hypotension is also a problem. And then we're often referred patients from GPs with elevated parathyroid hormone levels who don't understand that this is to do with calcium, and they're sending them in for sestamibi scans and ultrasounds and parathyroidectomy. And fortunately, they get sent to the metabolic obesity service where we can help them with their calcium replacement, rather than ending up with all these investigations through the endocrine clinic. But it does lead to this perception in the public sector that complications from bariatric surgery are far more common than they actually are in reality, because we're just seeing this biased sample of the population. The next thing that I wanted to talk about was medical therapy versus bariatric surgery. And there's already been a lot spoken about this at this conference, and clearly at this point in time, bariatric surgery remains superior in terms of the amount of weight that you lose with these anti-obesity pharmacotherapies. We've got randomised clinical trial evidence in type 2 diabetes that it's superior to medical management, albeit without the most modern anti-diabetes medications. But the problem is these medications are coming and they're down the pipeline, and we all know they're going to be here soon. And that creates this perception of, well, should we just wait? Should we just wait for these highly effective pharmacotherapies to come rather than doing an operation on a patient like a sleeve gastrectomy, which isn't reversible, that they're going to have to live with long term? And some people, not my personal opinion, do see it as being a sort of mutilating operation. But there are issues here, because the pharmacotherapies are not subsidised through the pharmaceutical benefits scheme. They're unlikely to be subsidised through the pharmaceutical benefits scheme for everybody with obesity. And when we're talking about public bariatric surgery, that does come to the patient at no cost, zero cost. So a highly expensive therapy that may be efficacious, but something versus something that is actually free. We've also got to be realistic, I think, as clinicians, that adherence to pharmacotherapy is poor, even with these new agents. And it's no surprise to everybody that there has been a real problem globally with the reliability of supply of these pharmacotherapies. And once people stop taking them, they regain weight and they lose all the health benefits they had from being on the medications. So the problem, I think, is that the promise of these highly effective pharmacotherapies has led to a degree of treatment inertia. So I think there may be a situation where now we're prolonging years of untreated or poorly treated obesity waiting for these new pharmacotherapies to come. And this is a particular problem, I think, in type 2 diabetes, where we're waiting and waiting and waiting for these better and better therapies to come. Now, I am going to bore you with something very, very medical on the next two slides, so bear with me, because I'm going to talk about the UK PDS study. Now, the UK PDS study was the landmark diabetes trial, which started in 1976. So my claim to fame is I'm almost the same age as the UK PDS study. But the UK PDS study was really important because it showed us that early intensive treatment of type 2 diabetes has a legacy effect that persists what looks like lifelong, because we're now 24 years post UK PDS, and early intensive therapy at diagnosis is still clinically significant for reducing any diabetes-related endpoint, whether you're on the sulfonylurea and insulin arm or the metformin arm. It reduces myocardial infarction, so this is 40 years down the track. It reduces microvascular disease outcomes, and it reduces death from any cause. So if we're just having people sitting in our clinics with their diabetes not in remission, not adequately treated because we're not giving them bariatric surgery, they're at risk of not getting benefits from early, highly effective care. So what about attitudes to bariatric surgery? So this is taken from the ACTION-IO study. So this was a study that was sponsored by Novo Nordisk, so that's a caveat. It surveyed about 14,000 people living with obesity. It was done in a multinational population. And it also surveyed several thousand healthcare practitioners. Interestingly, bariatric surgeons were excluded from being in the healthcare practitioner arm. But I'm just highlighted there in two boxes. So there's one that looks at prescription weight loss medications and one that looks at weight loss surgery or bariatric surgery. And this is asking the people with obesity, which are in the orange, or the clinicians who are in the green, how effective they perceive these to be for the management of obesity. And it's pretty damning, really. So 40% of people with obesity think prescription medications work. So only 2 in 5 people think they work. Scarily, only 3 in 10 doctors think they work. In terms of bariatric surgery, you're doing better. So 6 in 10 patients think bariatric surgery is effective, but, and this is the kicker, only about 1 in 3 doctors think bariatric surgery is effective. So bariatric surgery has a perception problem. People just don't think it works, and that needs to change. So the next question is what was alluded to by the previous speaker is do we as physicians in public weight loss clinics create unnecessary barriers to get people ready and referred and going on to surgery? And this is something which personally I get very frustrated with, even working in my own service, because there's all sorts of caveats that we put on people before we will refer them on to the surgeons. And it's almost like, and not people don't really think this, but it's almost like people think there's such a limited public resource that people almost need to deserve it. And we don't think that, but it's almost like that. So if you haven't come to your appointments, if you haven't looked like you've really tried to lose weight medically, if you haven't done all the mandatory checklist in the order that we want you to do it, well, you're not really the right person. You're not really eligible for surgery. And we need to change that attitude, because we wouldn't need bariatric surgery if we had highly effective therapies. That's why people need the surgery. So I think we do have these caveats where in New South Wales we had one, it's gone now, but people had to do a mandatory 12 months medically supervised weight loss to be eligible. Why? There is no evidence that that makes a difference to outcomes. Lifestyle changes, being able to follow the appropriate post-bariatric surgery diet, but before you've had the surgery. How could you adhere to it? It would be impossible until you've had the surgery. And smoking cessation is another one that I've put up, not because I don't think it's important that people stop smoking, but if you've had someone who's gone from smoking 120 cigarettes a day down to 5, we were not referring them until that number was 0. And does that really matter if it's only 5 cigarettes in a day? So I'm going to conclude there, but I think the biggest one is I think the attitudes to bariatric surgery need to change throughout the medical community and the public perception. Public bariatric surgery, at least in my state, in New South Wales, is a very limited resource. And I really wonder whether it should be a statewide service, like liver transplant. Why not have it coordinated centrally so that the most eligible people get access? I think the new pharmacotherapies, I'm an endocrinologist, they're extremely exciting and extremely promising, but we need to be mindful that we're not having treatment inertia while we're waiting for them to arrive. And I think cost effectiveness analyses are really important so that we can make cases to our CEOs of our hospitals to get more funding. Because trust me, George, if they just listened to me because I was a physician, life would be really easy. So thanks very much.